Thank you, everyone, for joining us for today's Ask the Ataxia Expert session. I'm Lori Sjogren. I'm the Community Services Director for the National Ataxia Foundation, and I'll be assisting with today's session along with a few of my colleagues. All right, so now it's my pleasure to welcome back our resident ataxia expert, Dr. Susan Perlman. Dr. Perlman is the clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Thank you so much for having me back. Hopefully my audio is behaving itself. And I see we have some questions already. And one thing I've been noticing in clinic and just in life in general is that pretty much every day I will learn something new. Sometimes patients will bring me stuff that I was totally unaware of. Sometimes I'll see something in the news that I was totally unaware of. So, I thought I'd open up with something new that I've learned, and then we'll take a look at the questions and see what, things people are bringing up on their own. So, listening to the news on the way in today, nothing really new. So I Googled ataxia news and came up with a nice AI, beautiful, grammatically perfect paragraph with, references as AI has been doing. And they mentioned a new autoantibody that can cause immune-mediated ataxia. This is anti-DAGLA, which I had not heard of. It was just reported late last year and another couple of articles in the medical literature this year. It's an autoimmune ataxia, but is interesting in that it progresses more rapidly than the anti-GAD ataxias and some of the anti-YO that we're aware of. So I learned that there's a new autoantibody, and my next question was, is anybody testing for it outside of a research lab? And the Mayo Clinic already has a test for it. So, it's something that we can look at when we're thinking of non-genetic ataxias, that, we should be sure to cover the bad antibody, area as well. So one of the first questions is from Matthew. Modafinil is on the NAF list of medications that can help with sleepiness and low energy. And it was originally approved for people with excessive daytime sleepiness because of a sleep disorder. So, and then it became more generally used for low energy and fatigability. So Matthew asked his neurologist, and she suggested Adderall instead. Modafinil does stimulate adrenaline pathways. Adderall definitely stimulates adrenaline pathways. Any negatives from using Adderall? I think one of the concerns about Adderall is that the benefits may wear off. Your body may get used to it. I haven't seen that happen with modafinil. This individual has SCA6, unsteady on his feet, using a cane outside. You wonder if something is stimulating an adrenaline-related pathway. Could it make tremor or shakiness worse, kind of like caffeine would? And, if the fatigue that you have is significant enough that you want to try something, you can try Adderall, use it, cautiously, lowest possible dose, see how you feel. Sometimes it's hard to get authorization for modafinil if you don't have a documented sleep disorder. Now, Sean is asking for new insights, number one, about the FDA approval for release of troriluzole. Also, why Biohaven sought approval from the EMA to market for SCA generally, as opposed to leaving its request restricted to SCA3. And the EMA is the European equivalent, as it were, of our FDA that will authorize new drugs for marketing in Europe. So the FDA story with troriluzole has been a long one. They have given guidance to the development of troriluzole basically the whole way working with Biohaven in how to measure benefit, what things to look for when you're collecting data. So, we're waiting to hear, within the next month or two about possible approval of troriluzole based on this large collection of FDA-directed data that was submitted. So it's basically waiting now. Troriluzole has been made available, is expanded access in the United States, for patients with SCA. Now, will it be approved just for SCA3, which had the best original data, or will it get a general indication for spinocerebellar ataxia? And that is, again, another unanswered question. I think the feeling is that because the extended data analysis included all of the spinocerebellar ataxia subtypes that were in the study, not just SCA3, that should it get approved, it will be for general SCA use, anywhere from SCA1 to SCA51. And, obviously the approval in the European market is going to depend on, how the FDA structures that. Anna Maria has a question. What is the connection between AOA2, ALS, and SCA? So a genetic test came back, likely pathogenic for AOA2, and the phenotype is mentioned first AOA2, then ALS, and SCA. MRI showed cerebellar atrophy, which can occur with AOA2 and can occur with SCA. And what is the difference between an MRI from a person with ataxia and an ALS person? I am not that conversant with MRIs in ALS. I would suspect there's more generalized atrophy, since ALS is a motor neuron disorder, which involves upper motor neurons as well as spinal motor neurons. It may also have some atrophy in the cerebellum, while the SCAs and AOA2 will have cerebellar atrophy. Now, the relationship between various genetic defects, we know that the gene for SCA2 can have low-grade mutations that are risk factors for ALS. I'm not 100% conversant with the connection with AOA2 and that group, but it's something that I can look up and then get back to, and Lori will keep track of this, and I will make a note. But a mutation in one gene may influence the behavior of other genetic factors, or large mutation, small mutation could open up a risk pathway for an environmental factor. So it's a little more complicated from when Mendel first discovered, the role of genetics in his plant work. Okay, Efrat, is sending a greeting. Ruth has been diagnosed with episodic ataxia type 2 that has progressed to include Parkinsonism and dystonia. Episodic ataxia type 2 typically will progress to include consistent ataxia, not just episodes, but there will be some ongoing ataxia in between attacks as well. And most of the ataxias could include other parts of the nervous system, the basal ganglia that mediates Parkinsonism and also mediates dystonia. So Ruth has been taking 1,000 milligrams of acetazolamide, not really controlling ataxia symptoms anymore. Dalfampridine did not seem to provide benefit, although dalfampridine is recognized by the American Academy of Neurology as being also effective for episodic ataxia. Doesn't work for everybody. And then Ruth is reminding me that I had talked about the compounded formulation of dalfampridine for aminopyridine, which is an immediate release formulation. I have had patients who have tried the immediate release before they could get the prescription formulation of dalfampridine. Dalfampridine is extended release. they felt they got better results with the immediate release. Some understanding that the immediate release may have a high risk of causing seizures, but dalfampridine in general, 4-aminopyridine, whether it's immediate release or timed release, that is a risk at higher doses in people that may be sensitive to that. Now, Ruth is currently on a trial dose of lacosamide. I am unaware of lacosamide being used to treat episodic ataxia. I know episodic ataxia type 1 is dilantin responsive, and lacosamide is another anti-seizure drug. So its use for episodic ataxia type 2, I'm going to check out. Type 2 has not been known to be responsive to anti-seizure drugs the way type 1 is, but we're learning more, from year to year. Talking about lacosamide potentially having, behavioral changes or could cause suicidal behavior. Any drug that gets into the brain has been recognized by the FDA as potentially having a risk to change mood, to contribute to depression or suicidal behavior, so that any new drug that is in testing has to have, a survey for patients in the study of mood and suicidal thoughts. Okay, Israela Marcus has advanced stage Machado-Joseph's disease with a SARA of 13. Now, the SARA scale goes up to 40. So 13 is kind of in the middle, regarding, rating on that scale. This person has access to being treated with stemchymol in Taiwan or troriluzole in the USA. So which of these two drugs seems to show more promise? And are there any other current experimental drugs worth considering? So the stemchymol study, which has been in Taiwan, has been in South Korea, has been in Japan for SCA2, SCA3, Machado-Joseph's disease, and SCA6, will be coming to the United States next year. Not clear if it's going to be restricted to just Machado-Joseph's disease. And it's not clear that the group in Taiwan is recruiting new patients. So I'm not clear about that. Now, troriluzole is on the threshold of being approved in the USA. So I think looking at the two drugs, troriluzole, protects the Purkinje cells, strengthens Purkinje cell performance in the face of an ataxia that's weakening Purkinje cells. The stem cell treatment that is being developed, in Taiwan is felt to stimulate neural regeneration. It's neuroprotective. So both of them, in a way, are neuroprotective. There's data suggesting the stem cells that are developed, in Taiwan are helpful. And there's a lot of evidence showing that troriluzole can improve symptoms and stabilize and slow progression. So stemchymol is administered by an infusion on a monthly basis, how many months that you would have to take, and a break in time. Would you take 3 months on, 6 months off? They haven't quite figured that out yet. Troriluzole is an oral drug taken every day. I think they both have promise, and hopefully both of them will be approved and will be in our armamentarium. Now, Joel has a question. Are there studies linking ubiquinol or any other supplement to ataxia? And Joel is 64 and has Fragile X tremor ataxia syndrome, which is a genetic disorder. So work with antioxidants like ubiquinol, CoQ10, omega fish oil, and vitamin E, and many others has been going on, basically since before the genes were known. It was recognized that degenerative progressive brain diseases, probably parallel what's going on with brain aging, where free radicals, oxidative stress is part of the problem. And antioxidants have been popular for many, many years. I don't think there's any evidence that using an antioxidant supplement of any type will stop progression of the disease. They may improve certain symptoms. Fatigability is one that people say is benefited by antioxidant vitamins. Theoretically, if you were to start an antioxidant vitamin very early, it might delay onset of symptoms, but that hasn't been definitively proven. So in using supplements, use them for a very, restricted period of time. 3 months is usually enough to let you know if the antioxidant you chose is helping or not. And try one at a time. Don't start 5 different ones at the same time. If you got a side effect, you won't know which one it is. Fran has a question. After 10 years, can ataxia brought on by reactivation of Epstein-Barr virus after lumbar fusion surgery ever been cured? So chronic Epstein-Barr neuroinflammatory acquired causes of ataxia, which can be reactivated. You've had Epstein-Barr virus in the past, it's settled down. You had Guillain-Barré in the past, it's settled down. Various stressors can reactivate that symptomatology, whether it's a surgical stressor or another illness or COVID, could reactivate. So, a reactivation from an acute intervention of some type should settle down slowly over time. If this reactivation occurred 5 years ago, at the start of COVID, as an example, you had an ataxia caused by Guillain-Barré, you stabilized for many years, you caught COVID, the ataxia symptoms or the neuromuscular symptoms got worse 5 years ago and are still not better. It's possible that that added damage, as it were, is probably not going to resolve. You would look for recovery after an acute insult, usually within 1 to 2 years. Now, Jenna has a question about the soonest date possible for gene editing to come out for SCA. There are gene therapies for SCA that are in development, and this goes back to the prior question, which I did not answer completely, about future therapies for SCA, whether it's SCA3, SCA2, SCA1, or some of the rarer ones. So the current approach to gene therapy started with ASOs, antisense oligonucleotides, that could target the messenger RNA that was produced by the genetic mutation that would then be producing a defective protein, either a protein that had a gain of function, the CAG repeats we're all familiar with, or another mutation, so that the antisense would destroy the messenger RNA, target it for destruction, so it couldn't make the bad protein. And that was the first step to gene editing, as it were. We now have several companies working on antisense technology for the SCAs. Vico in the Netherlands is one. They have a program for SCA1 and SCA3. Cure Rare Disease in the United States is working on SCA3. Arrowhead is, has a similar protocol for SCA2. Now, true gene editing, actually fixing the gene mutation, would involve using CRISPR technology or related technologies. And I think the soonest we're going to see a human trial from any company that's working on a way to permanently remove the mutation from the gene is probably going to be, not in 2026, I think maybe 2 years from now, with good safety data in animal studies and good development. We may well see in 2027 a human trial for gene editing for the SCAs, and I won't go any further than that since I don't have any more information. Karen, does dalfampridine have any effect on the urinary system? Since this particular person has a neurogenic bladder with urine retention. I spoke with a patient recently who tried dalfampridine and developed urinary urgency, where they had trouble controlling their urine as opposed to retaining urine. Now, dalfampridine does work on episodic features. It also works on upper motor neuron features. And its approval for use in multiple sclerosis was based on its impact on the upper motor neurons, spasticity of gait and walking. Now, a neurogenic bladder can be neurogenic on the basis of upper motor neurons, which could cause urgency and incontinence or could contribute to retention. So I would hope that somebody who was trying dalfampridine for a motor problem, an ataxia problem, or a spinal cord or an upper motor neuron problem, if they were having bladder issues, to monitor how the bladder did. It shouldn't, by definition, make the bladder worse. Like I say, I had one case where it seemed to increase urgency. So if you have tried dalfampridine and have had a benefit for your bladder symptoms, it's something I think we would like to know. Oh, this is a good question from Pauline. Which magnesium is best for SCA27B? I haven't heard about magnesium being used specifically for SCA27B, although magnesium is used for a variety of neurologic symptoms that can occur with the SCAs. And I believe magnesium glycinate is currently favored. And I think I can check on that as well and see if I missed something about SCA27B that was specific for magnesium. Now, David has been diagnosed with CANVAS. It's a recessive adult onset ataxia. Prognosis is poor, so I don't know what that means, except it has symptoms that are going to be, a struggle to manage, as all ataxia symptoms are. And there's currently no disease-modifying therapy, although there is a lot of research going on around the globe in how CANVAS mutations cause damage to the nervous system and how they can be interfered with. So, the best treatment that I think all of us would recommend, good physical therapy, a good home exercise program, occupational therapy, speech and swallowing therapy, if appropriate. That's the foundation. Now, the symptoms of CANVAS, cerebellar ataxia, neuropathy, and vestibular, atrophy or atonia syndrome. So there's going to be ataxia, there's going to be peripheral nerve problems, which could cause numbness, could cause pain, as well as vestibular dizziness, which can complicate management. Treatment of the neuropathy does have a lot of options. Gabapentin, I think, is very popular to calm down any discomfort from the neuropathy. If the neuropathy has led to restless legs or sleep disturbance, there's a lot of good interventions for that. And for the ataxia, rehab is still the best way to go. Riluzole or troriluzole can be symptomatically beneficial as well. Amantadine is an old drug that still can be helpful with ataxia. And I think the dizziness that can accompany CANVAS is probably the hardest symptom to manage. And on the National Ataxia Foundation website, they have their list of, how to manage various symptoms of ataxia, including dizziness, a long list of medicines that have been tried for dizziness, may be helpful, but often it's a struggle. There are rehab groups that will work with physical therapy techniques to try to, reduce dizziness in patients. Carol has a question. Can you improve neuroplasticity of your brain with this genetic ataxia with high-level balance exercise? So we know that good exercise, cardio, strengthening exercise, rhythmic repetitive exercise can protect muscles from becoming innocent bystanders, can stimulate pathways that control balance and coordination to communicate better with each other, so that you can enhance communication from the cerebellum to the brainstem to the spinal cord to nerves and muscles with good exercise, incorporating many of the types that I just mentioned. Neuroplasticity means, can exercise encourage nerves to grow back, to reconnect, or stem cells that we may have in our brain to become active, to reinforce the pathways that are under genetic stress? So we know from animal models that cardio, good exercise that gets the heart rate up can, in the animals, push off onset of ataxia by stimulating nerve growth factors, which can then stimulate neuroplasticity. So I think a good exercise program and high-level balance exercise, hopefully it includes some cardio, can absolutely help. We know that aggressive exercise can help stroke recovery even 5 years down the road, and that is obviously working on neuroplasticity as well. Does a gluten-free diet help with genetic ataxia? So, what was found with the British group that has been very active in the gluten-related neurologic disorders is that the gluten allergy, the antibodies produced in people who are sensitive to gluten can cross the blood-brain barrier and can cross-react with the cerebellum and cause ataxia all on their own. It can also cause peripheral neuropathy. So there is cross-reaction with gluten antibodies and parts of the nervous system. Now, a degenerating nerve in the cerebellum, produces fragments that trigger the immune system in the cerebellum, and could make low levels of antibodies that cross-react with the gluten antibodies. So theoretically, a gluten-free diet will reduce any component of the gluten in the diet as it might interact with the immune system and accelerate, these autoantibodies either being produced from genetic neurodegeneration or from an actual gluten issue. So, plus the gluten-free diet limits simple sugars, limits obviously carbs through flour, and that alone, even if it isn't strictly gluten-free, just limiting simple sugars and white flour can improve fatigability and energy levels. And I think this is true for SCA27B as much as for any of the other SCAs or any of the other ataxias in general. We have an anonymous question. Does SCA2 affect sleep and cause insomnia? And are there any effective ways to combat sleep disturbances? So the cerebellum coordinates everything. So the sleep cycle is a rhythmic process that needs to be coordinated in some hand-waving way. I don't have all the details of that, but the brainstem is where the sleep center is that helps initiate sleep, helps maintain sleep rhythm, keeps you breathing while you're asleep, so that any of the ataxias could have a sleep disturbance, which could include, sleep apnea, where your breathing is not coordinated with your sleep cycle, you snore or may stop breathing periodically during sleep. It's a coordinated process that occurs quite frequently. The brainstem also mediates dream sleep. That's part of the sleep cycle, so that some of the ataxias will have what are called parasomnias, where they will have vivid dreams, nightmares, a disturbed sleep pattern on that basis. They may talk in their sleep, run marathons in their sleep, so that, and in danger of, obviously injuring themselves or falling out of bed or injuring their bed partner. So, I think SCA2 on any of these bases could have an impact on sleep. Could it cause insomnia? Now, many of the ataxias that have a peripheral nerve component, which SCA2 may have, can cause neuropathic pain, tingling, numbness, or discomfort, which can make it hard to fall asleep. SCA2 and other ataxias may have restless legs on a peripheral or central basis that can, wake you up. You've got to move your legs. It's that discomforting, not necessarily painful, but a discomforting sensation. So that all of these could be factors. And if you are having sleep disturbance, you can get a sleep study done. You can have a home sleep study that will show if you're having breathing in coordination. You can do a sleep study in a lab that will show some of these other factors that could be going on. So I think it's important to speak in detail with your doctor about the kind of sleep issues. Why are you having insomnia? Are you doing something at bedtime that's keeping you awake? Are you on your computer or on your smartphone? And that, computer activity tends to wake the brain up. Are you drinking too much fluids after dinner so that your bladder is overactive and keeping you awake? So there's a lot of things that may cause, insomnia in almost any person. So best to have a good discussion with your doctor as opposed to leaping to, is it this? Is it that? Should I try melatonin? Talk it out with an expert first. Do you have any association for canvas? I know that there are research groups that are heavily involved. I know that the European ataxia group does have a canvas, a canvas group that is devoted to canvas and probably has interactions with the patient community there. I know that the National Ataxia Foundation Facebook groups, there are several canvas groups on there, so that you can work with other individuals with that diagnosis. You can have contact with some of the research groups that will give periodic updates. Joe has a question. In the clinical trial of SLX 100, is it possible to measure the placebo effect for those receiving placebo could otherwise feel improved if taking dalfampridine? In any clinical trial, the placebo effect is strongly seen in the first 3 months. In fact, just in your everyday life, you start taking a new vitamin. For the first 3 months, you're probably going to feel better, even if the vitamin is doing nothing. And the placebo effect is a real neurologic effect. It's mediated through endorphin pathways, so that it bumps up the endorphin signal, which can make you feel better, do better in a lot of ways. After 3 months, the placebo effect declines, so that most clinical trials that are being run, have to run longer than 3 months if they want to sort out placebo benefit from the benefit of the drug. If you have been on dalfampridine for longer than 3 months and are still feeling improvement in certain areas, it's most likely the drug helping you and not just the placebo effect kicking in. Another anonymous question: are there any known protective genetic factors in SCA2 that could delay onset or slow progression? So, and is there a way for patients to get tested for them? There's a lot of research going on in the genetics of the ataxias. They're finding new ataxia genes, annually, at least one new one per year. They're finding interactions between the genes and looking at, genome-wide other factors, factors that could be risk factors, factors that could be neuroprotective factors. They are finding genetic pathways that seem to ameliorate or slow onset or slow progression of a variety of neurogenetic disorders. Huntington's disease is one, and then the ataxias as well. And we would have to go back to the literature to find out about other genes with respect to the natural history. And the natural history studies going on now, is sponsored by the National Ataxia Foundation, is collecting this information. And I have to check back and see what the most current publications are. So Kim has a question. Do you think Idebenone might have potential for ataxia? Idebenone is a form of CoQ10. It's the CoQ10 molecule that has been shortened so it gets into the brain better. It had a study done in Friedreich's ataxia. It had several studies done in Friedreich's ataxia. It had prior studies that were done in Alzheimer's disease. So again, as an antioxidant in the family of antioxidants like CoQ10, there could be symptomatic benefit. It's worth trying, just like CoQ10 is worth trying. And I think, we know that in not just in Friedreich's ataxia, which is a mitochondrial disease, but other ataxias, the mitochondria become innocent bystanders. And Idebenone could help with fatigability or other symptoms, and it's safe enough to try. Another anonymous question: how do modifier genes like DNA repair genes matter in SCA2 compared to Huntington's disease? Could they become drug targets? Excellent question. A lot of what we know about genes and genetic interactions one to the other, we've learned from Huntington's disease, which had about a 10-year head start on the ataxias in this area. So that something that appears to be a factor in HD could absolutely be a factor in the spinocerebellar ataxias. HD is also a triplet repeat expansion, polyglutamine disease, just affecting a different gene from the ataxia genes. So that one of the newer discoveries in Huntington's disease, and I think it also applies to the spinocerebellar ataxias, for years we thought somebody's born with a mutation in the Huntington's gene. Why do they not develop symptoms until they're in their 30s or 40s? What is it that leads to, the body being able to protect itself for the first 30 years and then losing that ability? One thing is brain aging. We know that as the brain ages, aging kicks in your mid-30s, and you begin to lose reserve and the ability to push back against stressors like genetic stressors. So a simple explanation: bigger mutation could come on earlier in life, as we know in SCA2 and SCA7 and some of the other SCAs. So what about DNA repair genes? And I first learned about this. This was the new thing I learned last November at a conference, that the mutation in brain cells, you figure you're born with a mutation, brain cells, don't grow back, the ones you have are the ones you have, and the mutation in them should be a stable mutation, as opposed to the mutation in blood cells. If it's being measured in blood over time, blood cells reproduce each other, a lot of, red cells every 3 months, the others more frequently, and the DNA, is being constantly reproduced as new cells are made, and the mutation could get bigger. But in the brain cells are stable. The mutation should be stable. However, exposure to cosmic rays or other things causes DNA breakdown in all the tissues of the body, including the brain. So there's a DNA repair apparatus that repairs the DNA so that the DNA in all of our cells is strong and connected and can do its normal job. So if the DNA repair apparatus is operating in the nerve cells, repairing stretches of damaged DNA, and those stretches tend to overlap the mutation, the expansion, for instance, it could repair, as it were, the expansion and make it bigger. And they were finding in Huntington's disease brains that over decades, what could have been considered a small expansion, 45, could have expanded in the brain of an older adult to hundreds of expansions, and that potentially the onset of disease is not based on the original modest expansion, but on the expanded expansion that DNA repair allowed to happen. So there is thought that you could target the DNA repair pathway, which is very complex. A lot of intersecting genes coordinate DNA repair. So which one are you going to block? There are diseases where DNA repair is compromised from a genetic mutation that cause cancer, that cause other cerebellar problems. So if you block DNA repair to hold that increasing mutation at bay, will you be opening up the brain to other disorders? So I think this is a tightrope that's being walked right now, but it was definitely a breakthrough in understanding what happens, in the spinocerebellar ataxias and SCA2. Serena has a question about autoimmune ataxia. Her neurologist thinks that she must have this because the genetic testing is negative and progression is so slow. So First of all the ataxia genes in the world have not yet been identified, and there may be new genetic factors that have been found in the last 3 to 4 years. We found the gene for Canvas, we found the gene for SCA27B, which seem to account for a fair number of adult onset ataxias in people who were not known to have a genetic factor before. So don't give up on continuing to update genetic testing from time to time. Now, slow progression is typically associated with genetic disorders. Autoimmune ataxia may have intermediate progression. So while a genetic ataxia is going to progress over 5 to 10 years, an autoimmune ataxia will typically progress over 2 to 5 years. And that's not slow, so that from year to year, you would notice things worsening. Now, this, isn't a rule by any means, but, I think the general feeling is that slow progression, you think genetic, intermediate progression, you think autoimmune, vitamin deficiencies, poisons, toxins, acute, sudden onset is typically something like a stroke. So, and as I said in my introduction, one new thing I learned is there's a new antibody that has been found. So, have you been screened for, the known autoantibodies that can trigger a cerebellar disorder? If he has a strong suspicion that it is an autoimmune ataxia, maybe from other factors, you may have other immune system changes that put you at risk for brain autoimmune changes as well. Have they tried a trial of steroids? Have they tried plasmapheresis? Have they tried intravenous immunoglobulin to see if you get a response? Usually the first thing that's tried is a steroid trial. And if that responds, you don't want to stay on steroids forever, they'll then move to plasmapheresis or IV intravenous immunoglobulin. So this is something to pursue, since the autoimmune ataxias in general are treatable. And the genetic ataxias are hopefully, going on that way as well. Okay, Karan indicates it was diagnosed with a variant of AT. I presume AT, I don't know, it's either AT abbreviation for ataxia or AT ataxia telangiectasia. Currently confined to a wheelchair and has cervical dystonia as well as neuropathy. In the few months that have passed, has developed some bladder retention. What do I recommend for this? Should he start riluzole? If so, what dosage? Okay, so we're dealing with symptoms that have become bothersome or disabling. Being confined to a wheelchair, potentially because of the ataxia. The cervical dystonia means that basal ganglia symptoms are involved. And the neuropathy we've already talked about, peripheral nerves may also suffer from various genetic factors, as, the nerve supply to the bladder as well. So you can treat each of these things separately. Riluzole has some history suggesting it could be neuroprotective. It's used in ALS as a neuroprotective agent, and has some European evidence that it can be neuroprotective in ataxia as well. So if you are looking for something that will slow progression, riluzole could be a trial. You could try it for 3 months. In that 3-month period, it might improve coordination. It shouldn't have any influence on the dystonia or the neuropathy, or the bladder function as we understand it. So the standard dose for riluzole is 50 milligrams every 12 hours, so twice a day. On the other hand, have you tried drugs that are active in the basal ganglia to help with the dystonia? Things like trihexyphenidyl, is commonly used for dystonia. And for neuropathy, if it's a painful neuropathy, we've already discussed the use of gabapentin, Lyrica, Cymbalta, a variety of things that are on the NAF list of treatment for neuropathy that could be helpful with that. I wish there were one drug that would help all of those symptoms, but currently you really have to piece together a selective menu of what you're going to use. But riluzole, definitely worth trying. Try it for 3 months and see how you feel. Tony has a question. Any update on the FDA approval of troriluzole? We are still waiting. So we'll, hopefully get some information before the end of the year. Miwa has a question. I'm Japanese living in the US. My genetic testing was negative, but did not include SCA31. Where can I get tested for this? I believe SCA31 is on some panels, that it is available. And one way to tell is to look up genetests.org or gene tests. You put that into a search engine, it'll bring up the NIH website that has a list of available genetic tests and where they're being done. So that if you just need a single gene testing, I would have your doctor, go to that website, find out which labs are doing it and where you can order a single gene test. And I can, look myself and get back to Lori about this after our session today. So another anonymous question, how promising is NeuroEPO as a therapy? And do you see any chance of that being available outside Cuba? NeuroEPO was something I just learned about from a patient. Like I say, I learned something new every day. It seemed to be, suggestive that there was benefit. And I was unaware that it is only available in Cuba. I'm going to look that one up too. You give me a lot of homework here to do. Another anonymous question, have any protective alleles been identified in families with delayed onset of SCA2 despite high repeat counts? This is research that is ongoing, and I am going to check into that and get back to Lori about that. Another question from Karan, is there a list of supplements you could suggest for ataxia, either generic or symptomatic? And these are going to be listed on the NAF website. They do have a section that talks about vitamins and supplements. The ones that most people turn to, the good antioxidants, vitamin E, CoQ10, omega fish oil, are the ones that are most looked at. Maria has a question. I'd like to know if there's a relation between SCA7 and central fever. My little one is in the last stage, I guess. Okay, so SCA7 is one of the repeat expansion ataxias that can get worse with each generation because the mutation gets bigger in each generation. 10% of the time it will expand to, becoming an adult onset disease to becoming a childhood onset disease. With the childhood onset forms of SCA2, SCA7, and there are others, the brainstem could be involved and most likely is involved. The brainstem controls sleep patterns, it controls fever, central fever. So, I think if as you're indicating here that you have a child who has this disorder and has been given a diagnosis of central fever, it could be an associated symptom on the basis of brainstem involvement. Now, here we have a number of questions from John. Let's see how many we can get through. This is, very good questions. Does UCLA use SIN1 biopsies to distinguish Parkinson's disease from spinocerebellar ataxia, especially types 2 and 7, or the ones that can mimic Parkinson's disease or multiple system atrophy? Yes, we are using it. And I found one of our movement disorders people that has the kits and is willing to, to do the skin biopsy and send it for analysis. And it is a useful test for sorting out synuclein-related disorders, especially where there can be mimics across, SCAs and Parkinsonian type symptoms. Are you aware of genes that are protective? We just had that discussion, and I'm going to check to see the level of research that we're at right now. Is research in progress to safely modify genes with abnormal numbers of repeat expansion? So, as I said, Arrowhead has an antisense approach for SCA2 to target the messenger RNA to prevent the production of the mutant protein. Ataxin 7, Ionis has a program that has been working on an ASO technology for Ataxin 7 as well. But I don't think they've launched a trial in humans yet. so that, things that will modify the messenger RNA in active study and development now. Other gene-directed therapies, there's great ideas that are being looked at, but still not ready for human prime time. Are SCA-related genes with a normal number of repeat expansion disorders considered safe or negligible concerns affecting ataxia? So these are the other SCA genes. I'm trying to understand this question, that don't have an expansion, but may have a mutation of a different type. I'm not quite sure what you're asking here. But any SCA-related gene that has a dysfunction in it, for instance, SCA27B, has two different types of mutations that give two very different phenotypes, but both of them will cause ataxia. SCA6, has two different types of mutations. One is an expansion, which causes, spinocerebellar ataxia type 6. The other is a point mutation, which causes episodic ataxia type 2, which can then progress to being a progressive ataxia. So some changes on a gene testing panel may be, listed as variant of unknown significance, small change felt to be benign. So you're right, some changes in ataxia-related genes may not affect the function of the gene at all, but others, have been documented to cause problems, sometimes only after years of studying individuals and families that have a supposedly benign mutation, which turns out to be the culprit after all. How do you or colleagues distinguish Parkinson's disease from spinocerebellar ataxia? So garden variety Parkinson's has a very classic, presentation. It has the resting tremor. It can have, slowness of movement and stiffness of movement, affecting, walking and other activities. So classic Parkinson's is indistinguishable. I mean, you're not going to mix it up with other things, except there are spinocerebellar ataxias that can have Parkinsonian features. SCA2 in the late onset form can have Parkinsonian features. SCA3 can have Parkinsonian features. And somebody with multiple system atrophy, a non-genetic ataxia, may present with Parkinson's-like features before the ataxia appears. So, I think if I see somebody with Parkinsonism, I will look for other clues that this might not just be garden variety Parkinson's disease, which is very common and very treatable in general. So, I'll look for changes in coordination that occur with cerebellar disorders as opposed to basal ganglia disorders. I'll get imaging, and somebody with a cerebellar ataxia will have cerebellar atrophy present even a few years before they develop symptoms. So you should be able to see on a brain MRI that the cerebellum is atrophied, the person has Parkinsonian type symptoms. You get a sense this is not going to be garden variety Parkinson's. So, I think, using the tools that we have, using our expertise, having seen many patients over many years, we can usually distinguish. But like I say, occasionally SCA2 can present with a Parkinson's type syndrome, and you won't see it until the ataxia becomes more apparent much later on. Is doing a SIN1 biopsy a reliable and safe way? Yes. And yes, we've already answered that. Yes, yes. Okay. Another anonymous question. What lessons are being learned from ALS and Ataxin-2 targeting therapies that could translate to SCA2 treatments? The small mutation in the gene for spinocerebellar ataxia type 2 is a risk factor for ALS. And the crossover of therapies, I do have a SCA2 patient that I put on riluzole after the European study suggested it could be helpful, for ataxia. And currently, this patient is also taking other ALS-approved drugs because SCA2 gene mutation, small mutation, is a risk factor for ALS. It doesn't mean that it causes ALS, but it's a risk factor. So I think any therapy that's being developed for SCA2 could potentially be applied to ALS. You'd want to do more genetic studies of the ALS population that you're going to be treating in. But this is I think a demonstration of the interchange between genetic factors, genetic risk factors, and degeneration in other parts of the brain where one area is going to help the other area. So I'll see if I can find any more information about where concomitant drug development is going on. Donna has a question. Does taking vitamin D help with circulation? I have no idea. It's, most of us as we get older, we can't convert vitamin D from sunlight as we do when we're younger. And we're recommended to take a vitamin D supplement because of osteoporosis. I don't know if it would help with circulation. Good question that, I don't know if you've Googled it yet. AI is going to give you a lot of very interesting paragraphs that it's been able to put together. But again, I don't know how it will help with circulation, but it's a good question. Another anonymous question, are there efforts to repurpose drugs that have been shown benefit in other polyglutamine diseases for SCA2? Absolutely. Repurposing drugs from other diseases is becoming very popular with high throughput screening. For looking for drugs that are already available that may have an impact on one of the genetic ataxias or non-genetic ataxias that we see. Susan has recently been diagnosed with SPG7. This is spastic paraplegia type 7, which may include symptoms of ataxia. Would like to know if riluzole will also slow down progression of this. I don't know that riluzole has had formal testing in SPG7, but it's worth thinking about trying for symptomatic benefit for an ataxic component, and also to see if over a period of time, it could stabilize progression or slow progression. Riluzole is reasonably safe for people to try. Monitor liver function early on, but it's, and again, it seems to be accepted as safe and reasonable to try. Okay, Jenna, we're still waiting for the FDA to weigh in on troriluzole approval. Now here's a question from Miwa. Does Hashimoto's encephalopathy mimic SCA? Yes, it can cause ataxic symptoms that could mimic any of the genetic ataxias or other non-genetic ataxias. Fairly easy to diagnose and should be treatable. Okay, Valerie has questions about double vision. I think we're reaching the top of the hour here. So many good questions here that I haven't gotten to, and I apologize for that. And so much homework that you've given me that I'm going to look up all this stuff and get back to Lori about that. So Lori, if you wanted to go through, all the rest of these questions and maybe isolate some that are unique that haven't been asked yet, send them along and I'll do my best to, provide some information about it. I learn along with everybody else.
You got it. And unfortunately, we are out of time today, but thank you, Dr. Perlman. Just another session of such great questions. We're always just so grateful to have you here and have your expertise. And this has been such an informative session again. And thank you all out there for attending and for all of your questions.
You will want to take a survey to see how many people are using AI to explore, an early question, which then turns into a very complicated question, as some of these questions were. AI, can have very good information, but I think we have to interpret it cautiously. When I looked up Ataxia News, it indicated that Selos was starting a study in ataxia. And I looked up Selos, and this is old news. This is from 4 years ago. So sometimes AI isn't quite as perceptive as we hope it would be. So you got to be careful a little bit. Right.
And that is a real warning for folks out there using AI. So you just never know. Like you said, it's like a high-powered search engine, but it's searching everything. And you kind of have to pick out and talk with other experts about what is relevant and up to date. I'll be following up with Dr. Perlman on all of those questions. And we hope to see many of you back for the next Ask the Expert session.
Good. Take care.
Take care, everyone. Till then.